This presentation offers a brief overview of the primary management of head injury. Surgical procedures and their nuances will be considered in a subsequent lecture. We discussed the diagnosis of head injury in a previous presentation. Briefly, head injuries occur in road traffic accidents. They occur consequent to falls. They can occur in contact sports. They occur with assault, and they occur in war. The common primary mechanisms by which the brain is injured include impact and inertia. Both mechanisms usually occur together. For example, in a road traffic accident, impact and inertia contribute to the total brain injury load. Skull penetration by sharp objects or by missiles produce injury along the track. In high velocity missiles, there is also a zone of injury around the missile tract because of kinetic energy of the bullet. Blast injuries injure the brain by transmission of the blast pressure wave into the cranium. Head injury includes both traumatic brain injury and skull fractures. The cardinal features of brain injury include a loss of consciousness. The depth of loss of consciousness reflects the severity of the injury. There is an amnesia of the event and for some time afterwards called post-traumatic amnesia. Duration of post-traumatic amnesia again reflects severity of the injury. Seizures may occur after a head injury, and there may be focal deficits depending upon the area of brain which is injured. Skull-base fractures often produce ENT bleed. There may be CSF otorrhea or rhinorrhea. Battle sign, which is a bruising of the mastoid, or raccoonitis, may be present. The clinical profile of a head injury includes impairment of consciousness. Consciousness will be quantified by the Glasgow Coma score, which we will discuss later. There can be cranial nerve palsies. Olfactory will result in loss of smell and of taste because the aroma of food contributes 80% to the flavor of food. Optic nerve injuries might result in blindness or in a field loss. Third, fourth, and sixth injuries will result in diplopia. Third will also produce a dilatation of the pupil. Mastoid region or petrous temporal fractures might result in a facial palsy, the seventh nerve palsy, and also with loss of hearing. Facial palsy may sometimes be salvageable with decompressive surgery, but loss of hearing is often permanent. Ninth and tenth fractures may result in difficulty in swallowing, and hypoglossal injury may be overlooked unless you ask the patient to protrude the tongue, in which case it deviates to one side. Focal deficits may be present. For example, a left-sided frontal injury may result in speech loss as well as right-sided hemiparesis. There may be features of increased intracranial pressure, Cushing's triad, bradycardia, hypertension, respiratory irregularities may be present. There also may be clinical features of herniation, subfalcine herniation, producing contralateral lower limb weakness because the anterior cerebral artery gets blocked. Transtentorial herniation, the lateral variant which produces the classical Weber syndrome of ipsilateral pupillary dilatation and contralateral hemiparesis, along with occipital lobe infarcts resulting in a contralateral hemianopia. Foramen magnum herniations are usually preterminal events with cardiovascular instability. Loss of consciousness is usually quantified by the Glasgow Coma Score. This score was devised by Janet and T. Steele at Glasgow in 1975. It includes three factors: eye opening, motor response, and verbal response. So the EMV scale. Eye opening. If there is no eye opening, even on pain, it is 1. Eyes open to a painful stimulus, you get 2 points. Eyes open on call is 3 points. And spontaneous eye opening is 4 points. If there is no motor response, you get 1 point. If there is an abnormal extension of the arms, you have 2 points. Abnormal flexion is 3 points. Flexor withdrawal is 4 points. And localizing pain is 5. Obeys commands is 6 points. Verbal response, if there is no phonation, you have 1 point. Groans and moans makes it 2 points. Single words is 3 points. Confused speech gets 4 points. And normal speech 5. As in all trauma, airway and breathing take precedence. Airway maintenance in head injuries is always done with cervical spine precautions, because the cervical spine is injured along with a head injury in 8 to 12% of cases of severe head injury. Maneuvers which are preferred include chin lift or jaw thrust with neck extension used minimally. Airways may be non-invasive. You can have an oropharyngeal airway or you can have a nasopharyngeal airway, but avoid nasopharyngeal airways in case the patient has got a epistaxis. Endotracheal intubation is indicated for 2 reasons. One is if there is airway compromise, and the second is if there is inadequate ventilatory effort. Airway compromise or protection will be required in trauma-related causes, like there is bleeding into the oral cavity or there are mandibular fractures. Unconsciousness itself will result in airway compromise because the tongue falls back, vomits may be aspirated, and swallowing is impaired. Inadequate ventilatory effort is often present in an acute head injury patient when the Glasgow Coma Scale is low. Patients with a GCS of less than 9, that is 8 or less than 8, will require intubation and elective ventilation. The third basic facet of trauma resuscitation in head injuries is the maintenance of circulation. Normal cerebral blood flow requires a mean arterial pressure of 60 to 150 millimeters of mercury. Cerebral perfusion pressure is the difference between mean arterial pressure and intracranial pressure. If the cerebral perfusion pressure falls, then we have inadequate brain perfusion. There are other factors also involved in cerebral blood flow. There is a failure of autoregulation occurs after head injury. So even a MAP of 60 may not be enough. Many people would recommend a MAP of 70 or 80 so that cerebral perfusion pressure is maintained at a higher level. Hypotension after head injury is not common. If it occurs, we can suspect a brainstem injury. Much more common, however, is other associated injuries. There might be blood loss because of hemoperitoneum, hemothorax, or fractures of major bones or the pelvis. There may be a failure of cardiac contractility, cardiac tamponade might be present, or there may be myocardial contusion. Hypertension after head injury is often a compensatory response. It's part of the Cushing's triad. Cushing's triad is hypertension, bradycardia, and respiratory irregularities. IV fluids, which are started in a head injury patient, are usually isotonic or slightly hypertonic, as dextrose normal saline is, or normal saline may be enough. Hypotension is managed depending upon the cause of hypertension. If there is a low hemoglobin and a low hematocrit, suggestive of blood loss, blood and colloids are transfused. If the hemoglobin is normal, inotropes will be indicated. Seizure prevention is another important aspect of head injury management. Seizures may occur early, they may be immediate, it is within 24 hours. Early seizures are those which occur from day 1 to day 7, and late seizures occur after 7 days. Immediate seizures are often associated with the excitotoxic surge which occurs after a head injury. Early seizures are more likely because of a failure of inhibition. The lateral spread of impulses is usually inhibited by inhibitory interneurons. Inhibitory interneurons become dysfunctional after a head injury, which can result in seizures. Late seizures often result in post-traumatic epilepsy. Here, the cause is the creation of abnormal circuits. Neosynaptogenesis, which is the brain's attempt at restoration of function, may result in aberrant circuits which might produce seizures. Prophylactic antiepileptics are administered when the intracranial pressure is high, where the occurrence of a seizure may result in a catastrophic further rise in intracranial pressure. Phenytoin sodium and levetiracetam are both often used. Phenytoin sodium is usually given in a loading dose of 15 to 20 mg per kg, administered at a rate of 1 mg per kg per minute. Levetiracetam may be given in a 1 gram bolus dose in an adult. It is pertinent to understand that prophylactic antiepileptic drugs suppress seizures, but they do not prevent epileptogenesis. Management of increased intracranial pressure, or even prevention of a rise of intracranial pressure, should be started early. There are many causes of increased intracranial pressure after a head injury. Cerebral edema may be both cellular edema and interstitial edema. Cellular or cytotoxic edema occurs because of a failure of the membrane pumps, resulting in water and sodium entering the cell. Interstitial edema is attributable to an opening of the pores of the endothelium at the blood-brain barrier. This is because the astroglia, which support the endothelial cells, lose metabolic activity and retract their foot plates. Hematomas, which are mass producing, extradural hematomas, intracerebral hematomas, subdural hematomas, and even cerebral contusions will result in increased mass effect. This is because the Monro-Kelly doctrine that the normal intracranial volume contains a fixed volume of brain around 1200 or 150 ml of CSF and 150 ml of blood. Any addition of a further volume to the cranial cavity will result in an increase in pressure. Vasoparesis is a poorly understood but definite cause of increased intracranial pressure because of a loss of tone of the cerebral vasculature associated with a loss of autoregulation. There is an increase in ICP. Hydrocephalus occurs because of impairment of the cerebrospinal fluid absorption. Anti-edema measures include physical measures like raising the head end of the bed. By raising the head end of the bed to about 30 degrees, venous drainage from the cranium is improved. Ventilatory settings also play a role. A higher PEEP would mean increased intrathoracic pressure and decreased venous drainage from the cranium. PCO2 maintenance is important because a higher PCO2 will result in vasodilatation, which will result in an increase in intracranial volume. Osmotherapy involves increasing the osmolarity of the blood. Osmotherapy increases the osmolarity of the blood and causes a drawing of edema fluid from the brain interstitium back into the capillaries, back into the circulation. This obviously works better with interstitial edema. There are many agents which are used for osmotherapy. Mannitol is possibly the most effective. About 100 ml Etali is a standard dose in adults, which is considered to be low dose mannitol. Higher doses have also been used. Hypertonic saline increases the serum sodium levels when given as a slow infusion. Given as boluses, it can work like mannitol by decreasing intracranial pressure. Lasix or furosemide works by increasing the fluid excretion, thereby increasing osmotic pressure of the remaining circulating blood. Other aspects of head injury management include gastroprotection to prevent Cushing's ulcers. Proton pump inhibitors like pantoprazole and omeprazole have been used. Gastric mucosal protectives are also effective. In fact, some people prefer gastric mucosal protectives because a lower pH in the stomach may be associated with an increased risk of aspirations. Antibiotics are indicated in open head injuries. They are also given in surgical cases. Prophylactic antibiotics are given in severe head injuries, patients who are intubated, because most severe head injuries have an element of aspiration which has occurred. Aspirations to the lung will result in a denudation of the lining of the alveoli, making it predisposed to lung infections. Preventing aspiration is a priority. Prokinetic agents may be used. RT feeds are started, drive tube feeds are started early, not only for nutrition, but because motility of the gut decreases the incidence of infective complications. Skin care involves preventing fungal infections and prevention of pressure sores. It is important to remember that pressure sores occur not just trochanteric and sacral, but in unconscious patients also over the scapulae and the occiput. Care of the bladder, CVD catheters are used in all unconscious patients and in patients who receive mannitol. Patients who do not move their bowels after 3 days will require some kind of suppositories, enemas, or just laxatives.